Michigan on a snowy day. So a very interesting case. This is a nice 83-year-old patient. Comes to me from New Jersey with a set of implants that she had in 1983. So this is her one and only set from 1983. So this is the complaint that she had given the hard firmness, inability to move her arms freely, and also what is an MRI report that shows that the patient had what was a intracapsular rupture and an extracapsular rupture. And that is where she found me on the internet, on Facebook and YouTube, and she definitely learned a lot about what is, a ruptured silicone implant. And after all these years, 25, 35, 35 plus, and 42 years, she has these implants removed. And so as you will see, complete end block, 12/9/25, initial CH. Again, 83-year-old female presents with implants from 1983. You can see the contouring that I did between the right and the left to make the both sides symmetric. Now the one thing I want to show here is look at this protuberance right here, very abnormal. You'll see this is the part that was sticking out right here. This is how the implant was sitting, literally on the chest, and this part was sitting right next to and protruding at the level of the skin. You can see what is an irregular contour, another irregular contour, irregular contour, irregular contour, and normal tissue. Done end block, everything contained. I couldn't be happier with the minimal blood loss, extreme amounts of inflammation. And what I'm going to do now is, let me go ahead and go in from here. This is just to show you the intensity of how close it is to the surface. Because remember, it literally wanted to protrude out. She actually had like a skin biopsy for a skin lesion on the left side, and when they made the cut to remove the skin, they ran into silicone that started to pour out, and we will see that on the other side. So end block, the gold standard. If anyone says why should we do end block, obviously just the fact that her implants are from 1983 alone in itself is a reason to assume that both of them are ruptured, both intra and extra, because these are very old set of implants. Just to kind of give you a time frame, this is from the Ronald Reagan era. So as I go in, you will see right here is that implant, and this is where very hard and calcified, you can see. This is where no one should live with a ruptured implant. They talk about the health consequences of a ruptured implant are unknown. I'll tell you, it is not normal or healthy to have a ruptured implant. That's why they want you to get a MRI every 2 years. If you look at the Mentor guidelines, for the first time is at the 3 year after you got your augmentation, and then every 2 years they're onward. So as I cut this open, you will see everything is contained. None of this spilled into the chest. And that is the essence of what is end block. End block. So there is no spillage. Everything was contained. A lot of calcification. The body, as you can see, does an excellent job walling it off. And this is the whole purpose why this nice patient and her family flew out. You can see the implants completely disintegrated. I cannot tell by looking at it what is the make or the model, but you can see everything contained. Not healthy to have inside the body. As you can see, a lot of inflammation. They are not lifetime devices. And you can see right here, everything contained. What I'm going to do now is, a lot of inflammation around this tissue as well. So the purpose here is not only remove the entire implant and capsule, but all these irregularities that you see, these outpoutings, these, what is silicone granulomas. Look at how inflamed and angry this looks. I'm going to just, in the interest of inflammation, you can see, I should have cut open on the sides too, and we'll do that on the other side. And none of this spilled into the chest. And let me go ahead and move this around so you can see what was the inside. And I certainly want to take the time to cut this open to show you how inflamed and angry this looks. Very hard. Implants are not lifetime devices, and you can see, look at the calcification, the extra capsular rupture that's very much present. So what I'm going to do now is I'm going to remove my top sterile glove, and I have another green glove underneath. So as you will see, now this is a very tricky case right here. So this is, yeah, thank you. Go ahead and show this. As I was leaning forward, I got some of this slime, if you will, that ruptured implant. So it's on my gown here. As you can see, done en bloc, the gold standard. This is exactly how this was sitting right here. And this is the excess skin that I removed. So as I was peeling this off, you will see the patient stated that she had an incision. You can see the incision right here. And when they made the incision, there was silicone pouring out right here. And so as soon as I go in, you will see this is where I put the stitch here. And this was literally, if you look over here, look at the silicone. So I put a stitch in to basically cut this such that this extra capsular rupture is all contained, and the entirety of the implant and capsule is removed, as you can see, in this fashion, such that none of the silicone spills into the chest. And this is one of the tricks used to stop any of the spillage, and none of the silicone spilled into the chest. Now what I'm going to do here is I can feel the calcifications. I can see the thinness of the capsule right here, and as you will see, a lot of inflamed tissue. So I'm going to go ahead and go in from here. Let me go in from here. Use my fingers to dissect this. Here we go. Here's the silicone. You can see it's literally pouring out. And this nice lady was very well read on how I do it. En bloc, minimal blood loss, no need for drains, no need for the unnecessary lift. Even her age of 83, as you will see, and everything contained, none of this spilled into the chest. Very calcified. If you touch this, if I cut this open, hard like a rock. You can see the scales of a fish, literally very hard. None of this spilled into the chest. None of this was left behind. All the badness was removed. Look at the volume of this implant. Certainly looks a lot less because some of it has extravasated into the periphery. So it's not only important to do the implant plus the capsule that's severely calcified, but the inflamed tissue around, that's where the silicone has leached to. And let me go ahead and cut this open. A lot of inflammation. And you can imagine only how better she's going to feel once all of this is removed. So if anyone asks why the en bloc is key, so that none of this spills into the chest, no need for drains. So the implants will be returned to the patient, capsules to be sent to pathology, rule out the BIAL, CL, CD30 analysis, rule out lymphoma, rule out malignancy, cultures for aerobic, anaerobic, and fungal. Luckily there is no fluid on the inside, otherwise that would have been sent to cytology. No need for drains, no need for the unnecessary lift. The patient was on a weight loss medication, and so for that reason she has what is an endotracheal tube, and she just stopped that like a month ago. And I'm very happy and content with how the whole dissection has gone. She got the clearance, she was mentally prepared, she has good support at home, and yes, no one should lift what is ruptured implants. The implications are not good because we have silica that is present, and it's extra capsular rupture along with what is an intracapsular rupture, and she certainly deserves what is the same exceptional care that the 31-year-old patient that I talked to yesterday deserves, so that she gets the better quality of life and health, as you can see in the many years ahead that she has. So there you have it, en bloc, the gold standard. This is Dr. Khan, Executive Plastic Surgery.